Okay. Hello, everybody. My name is Jenny Sitchell. I am the Operations Director at the National Council on Independent Living. I help coordinate logistics for these events, and I wanted to welcome you all to our latest webinar, Innovative Transition for Individuals with Mental Health Disabilities. Today's presentation is brought to you by the Administration for Community Living at the U.S. Department of Health and Human Services in conjunction with the ILNet. The ILNet is operated by ILRU and in collaboration with NICL, April, and the University of Montana. Giving you a brief on myself, my pronouns are she, her, and I am a white female that is wearing a green shirt, short sleeve shirt, and has my hair pulled to one side in a braid. To go over a few housekeeping details, captions are available on this webinar. You can click Show Subtitle in your Zoom menu bar to turn them on. We also have captions running at AI Media. The URL is too long to read, but we will share it in the chat box. AI Media will allow you to enlarge the font and change the color and contrast of the captioning. ASL interpreters are present today and should always be visible as we are presenting in gallery view. Please let me know if you cannot see the interpreters. In addition to ASL today, we will have Spanish translation also available. In order to access that, you can go to the Zoom bar on your screen and choose the language you would like to hear the presentation in. You do not need to be on Zoom video to access this webinar. We will read all slide content and all questions out loud so that everything will be available to individuals calling in on the phone or who cannot see visual content. Public chat is turned off, but you will still be able to send chat messages to the host and panelists. We ask that you reserve the chat for requests for technical support only. Please do not use the panelist chat to submit content questions for the presenters. Speaking of questions, we will be answering all questions as time permits. You are welcome to submit your questions throughout the webinar, but please note that they will be held until the end of the webinar during the Q&A portion. There are a number of easy and accessible ways to submit content questions to the presenters. If you're on Zoom, you can simply type your question in the Zoom Q&A tab. You're also welcome to email your question to me at jenny@ncil.org. That's JENNY@ncil.org. I'll also put my email address in the chat box. Finally, if you're on the telephone today, you may press *9 to indicate you have a question. You can then press *6 when I call on you to unmute yourself. And we ask that if you are speaking a question, you limit the question to no more than 30 seconds. So we also ask that you complete our evaluation at the end of this. We take these evaluations so seriously, and they really help us to bring you these webinars, improve on the webinars that we're bringing you, and make sure that the content is right on track with what people want to hear. So we would be very grateful if you take a few moments to complete the evaluation with it. So now I am going to go through our slides here, what you will learn today. So we want you by the end of this session to describe the role of peer support in providing diversion strategies and alternatives to institutionalization for individuals in mental health distress. We want you to be able to identify best practices for outreach and support to psychiatric survivors to receive CIL services when they might not identify as individuals with mental health or other disabilities. And we want you to describe peer-run alternatives to hospitalization that include 24/7 peer-run respites run by people with mental health disabilities and staffed by certified peer specialists, and mental health and legal policy specialists. And this is our link to the evaluation survey. Make sure that it takes all of like 30 seconds to fill this out. So we want you to do this. It'll pop up when you leave the webinar. Just go ahead and fill it out, get it done, and we will be so thankful and grateful. Okay, on to the good stuff, everybody. So we have our panelists. We have Alex Makowski, Executive Director at Access to Independence of Portland County. Along with her, we have Jessica Hazel, a peer advocate, as well from Access to Independence of Portland County. We have Vicki Smith, Executive Director at the Alliance of Disability Advocates. And we have Vesper Moore, Chief Operating Officer at Kiva Centers and a board member at the Bazelon Center for Mental Health Law. So we're going to start this off. Jess, I am going to invite you to the screen if you could turn on your camera and your audio, Alex and Jess, and we'll have you guys get started.
Okay. Hello. Hello. My name is Jessica Hazel. I'm a peer advocate of Access to Independence. And this is me. I have purple hair, glasses, and dressed up in some glamorous jewelry. I'm a she, her, and here we go. So the first slide is basically collaborating a team of mental health professionals and myself. There are appropriate resources that are needed to be discharged and move on to the next level of transitioning. I'll be talking from my own lived experience as a person who went through all these transitions. Next slide. Options and choices. It can seem like there are no choices, but there may be some options you can choose from. It is important to try to do concurrent planning. This means to plan for multiple things at the same time. Talk with people who have gone through a particular program or the staff of that program to help you decide. Next slide. One of the options is housing. For instance, for my case, went through a halfway house. For some, you have nowhere to go, and a halfway house may be one option. There are single diagnosed and dual diagnosed facilities that will guide you to a safe path of living, with others to eventually living by yourself. Next slide. Housing option number 2. Another is going back to your original living conditions, but with safety standards in place, such as therapy, doctors, group sessions, and other community outreach programs. They'll help you safely plan ahead. Next slide, please. Being by yourself. Being by yourself doesn't have to be something to worry about. There are things in the community to keep yourself busy. Find your passion. Volunteer somewhere you would enjoy giving back to the community. More importantly, feeling important. Even doing something as little as coloring or going for a stroll in the park to enjoy fresh air can be helpful. Next slide. Motivation. In order to get out and doing things, you have to find a motivation, but motivation is very difficult. Think of the worst days and then think of the better days. Remember how you felt? The energy is quite different. Just doing something like getting fresh air boosts your energy and getting that sun on you. Doing something for someone else also helps make you feel better. It's all about getting through those few moments of a rough time so you don't have to go back to the hospital. Next slide. So there's a plan. Have resources in place, such as getting food stamps, counseling, insurance, an income, or social services to help get those insurance and income. Get appointments made with like a counseling or doctor, specialist, just in case something pops up, you don't know what's going on. Social services and a safe housing plan. Medication, get it all set and arranged to have it pick up. Have a plan in a pillbox form. Make sure you follow through 5 days ahead of time before you run out. Have a safety plan to make sure the meds are good. Next slide. And then more importantly, have a plan. So here's the plan. Safe housing or plan of a safe housing. Make sure it's safe. You have people around you that are a safe area. Plan of action when things get rough, what to do, who to call, where to go. Know your resources in the community that can help you. So if you need a safe place to go, resources to hook up with you. So if you have an eviction notice or where food pantries are, safe places. Next slide. My experience. My experience with hospitals has been different each time throughout my life. My first and second were out of my hands because I was a minor. I was living with my parents and I returned home. So I already have a home to go to. My third, I went in and I learned I was not able to return home and therefore I had nowhere else to go. So I had to put resources in place so I knew a safe place to go to transition properly. Next slide. In the hospital. While in the hospital, I applied for Social Security disability as a child due to my mental illness. I was not able to work. I was not able to go back to school because I was too sick to do anything. So the hospital helped me connect with a halfway house, and that took a month or so to get into. So patience is definitely an important thing to have because things take process and time. I then had to go apply for Medicaid and public assistance while waiting for Social Security. Next slide. After 10 months in the halfway house, I transitioned to supportive housing for 1 year in subsidized housing grant to help pay for my rent. Next slide. And look at me now. Currently, I am living on my own accord, working part-time, involved in the community, driving my own vehicle, paying my own bills, and mentally stable, enjoying life day at a time. Thank you.
Awesome. Thanks, Jess. So yeah, so my name is Alex. As previously shared, I'm the Executive Director for Access to Independence. Identify as a person with a disability. I've definitely gone to mental health counseling throughout my life in different stages and reasons. I have a speech disorder, so you might notice I stutter sometimes. I also have a disability in written expression. And today I have a red and black scarf on with a black and white dress and some pride things on as we're gearing up for a local pride festival. And I have some earrings in. I'm a white woman in my 40s. So I'm going to talk a little bit about trying to supervise people who experience mental health. And so the main thing that we try to do is try to have a collaborative and supportive environment. I've experienced supervisors and coworkers that have ranged from helpful with my mental health to not helpful at all or hurtful. So I have a few tips about how to create a positive work experience. Next slide, please. So at our ILC, we have many staff members who identify as people with mental health lived experience. And we treat mental health as a chronic illness, as it is, just like other chronic illnesses. It can have times when there are flare-ups or times that it's harder to function. Next slide, please. So the main thing is encouraging flexibility. Staff, when there are days that are harder, might ask for more remote days, or if they have a job that is supporting people in the community, they might want to limit the amount of public contact they have, or try to do things that are outside of their normal job activities that excite them or uplift them. And that can help kind of give a break from the stress of their everyday as mental health is struggling. Next slide, please. So the nice thing about having this creativity and working outside of people's normal job duties is we've found that people have a lot of skills they don't realize they have. And so we can find those things that they're good at, that they're passionate about, and that people have been able to move into other roles that might be more aligned with what they're passionate about at the time. So it's not just a positive for the staff, it's also a really good positive for the agency and the people that we serve in the community. Next slide, please. So boundaries is an important topic all the time, but especially important when we're talking about this topic. So my definition of what a boundary is sharing what you're comfortable with and what you're not comfortable with within a role. So I find giving people the space to vent or to work through their thoughts in the moment. I call that debriefing. Or sometimes discussing things after the fact to check in, to see what people's perceptions are, and work with them to have a plan to move forward. Next slide, please. Yeah, so boundaries ensure that staff know what can be discussed and what actions you might have to take. So for example, if a staff talks about persistent or severe thoughts of killing themselves, they have to know what actions you're going to take, which might be connecting to crisis services and staying with them until a plan can be made. Boundaries can also help prevent supervision or support into turning into a therapy session. Because even though I'm a therapist by trade, I am not my employees' therapist, nor the community members' therapist. So that's the boundaries help you to think through what you are willing or not willing to do, and also what you're licensed to do. Next slide, please. So tips for coworkers. The wonderful thing about ILCs is that we have a diverse team. There are people with all different kinds of disabilities and things that we're really good at and things that we're not. So some tips for coworkers is to try to figure out what skills and limitations each other has. And so our staff have found rhythms of when is it the best time to talk to a coworker about an unpleasant situation, or how to support each other when they're struggling with a consumer that had a setback or a challenge. And you know, some of our staff need help opening up bottles, and other people need confirmation that their anxiety is lying to them and they're really not a bother and they're doing a good job at work. Next slide, please. So a few tips about working with minors. And as my partner pointed out, I mean people under the age of 18, not people that dig in the ground for things. I've been working with young folks for the last 2 decades. Within each job, there was a different set of rules, but here's some of the basic principles that we've applied. While youth are not able to consent, it's really important to have their input because it's critical to engagement and to living out that independent living philosophy. Next slide, please. So even though it's not needed for them to sign that consent form, I really encourage youth to sign consent paperwork if they're able to understand it. So that depends on what their developmental level is and how they're engaging with the process. But if they get to the age of 10 and they're still not signing paperwork, it's a really good time to have that conversation about their involvement in the support. Because it's important that the nothing about us without us also applies to kids, which is our kind of mantra as people with disabilities. Next slide, please. So while you need consent to refer to non-emergency services, you don't need consent to give the consumer information for them to call themselves. So we do the same thing with community members that may not want to be open or may not want to sign that consent, but want support or information. The second important point is sometimes it's very easy to bash, quote unquote, or to put down the parents or guardians that are not playing an active role in the youth's life. So, but it's important not to give into that and to help the youth try to have a better understanding of how they're dealing with their parents or guardians support or lack of support. Next slide, please. So finally, understanding your rights. It's really important that as people that use services, we know who we should complain to or who has the oversight over this place that we're receiving help from. So hopefully you never, ever, ever have to contact a state oversight agency or a lawyer, but it's important to know where to go if you do. So we're in rural upstate New York, and in New York State, there is a legal program within the state for issues that might arise. So for example, you are admitted to an inpatient hospitalization, they want you to take medications, you object, you can have that mental hygiene legal person meet with you, go to court with you, and kind of help you through that process. So know that you have rights, even if you are secluded away and forced to stay there, and seek out support whenever you need it. Next slide, please. And I'm done. Thank you so much.
Thank you so much, Alex and Jess. That was awesome. Next up, I'm going to introduce to you all Vicki Smith. Vicki, do you want to pop on with your camera and voice? Give me 1 second and I'm just going to spotlight you. Okay, you're good to go.
Oh, my name is Vicki Smith. I'm an older white woman with gray hair and glasses, and I'm wearing a print shirt with black and gray beige colors, all in a pattern that is supposed to represent flowers. I identify as a person living with mental illness. I came to this diagnosis as a result of a breakdown that I had at a place of employment. I was not hospitalized, but I did have to receive pretty significant counseling and was unable to interact or go out of the house for several weeks. I've been working in the disability arena for over 40 years as a result. This is something that becomes a vocation for many of us, and some of us are just lucky enough to get paid to do this work. I wanted to, we're here today to share a tool with you. Some of you have maybe heard us talk about this before, but we call it measures of community participation. These measures are a list of things that people do in the community that include such things as going to church, getting a job, going bowling, going to a baseball game, just lots of different things that people do. We use this tool at intake when people come to us, and what we've found is if we can zero in on what they want to do and help them achieve those goals, that they are more likely to retain their housing. And retaining your housing is pretty important to community living. So it is a very critical thing that is being studied by Temple University. Let me say that these measures of community participation, we've talked about it on lots of different webinars over the last couple of years. And we will share them with you if you would like to have them. And all you would need to do is email either me or Corey McKittrick, who runs the program. And our emails are our first name. Mine is vicki@adaNC.org. And Corey's email is Corey, COREY, @adaNC.org. This is available at no cost. We think they make a difference. And it really allows us to zero in and find out what people want to do, what's important to them, and then help them remove barriers to achieving those goals. I could talk about this for a really long time, but I think the goal here on this webinar is to share information from many angles on how centers for independent living can really interact with and make a difference in the lives of people with mental illness. And I think there'll be opportunities at the end of our formal presentations to dig more into this. So I know I was really quick, but I hope that's okay. And we leave plenty of time for questions from people watching this webinar.
I think that's great. And I think that Corey is actually going to just put in the chat a link to the practice. So Corey, if you want to post, there you go. So that you guys can go visit this link and take a practice version of the measure that Vicki was just talking about. So thank you so much, Vicki. And I'm sure there will be a lot of questions for you at the end. And so now I am going to introduce Vesper Moore. Vesper, would you be so kind as to hop on?
I would be. Hello, everyone. My name is Vesper Moore. I use they, them pronouns. I'm the Chief Operating Officer at the Kiva Centers, and I am a board of directors member at the Bazelon Center for Mental Health Law. And today I'm talking about the Kiva Centers. We are a psychiatric survivor-run organization, trauma survivor-run organization. And in the mental health disability community, I think it's so essential that when we look at how we can really bridge cross-disability, cross-generation, I think peer support's a part of that. Mental health peer support's a part of that. And today I'm going to talk a little bit about the history of Kiva Centers, how we came to be. I'm going to talk about peer-run respites, and hopefully that'll inspire some of the independent living centers here and initiatives to work on disability-run peer respites, because I think that would be a great initiative. and to see in more spaces that how we can and will do this. So a little bit about our history. Our organization was born of the civil rights movement, and Kiva Centers was established as a direct result of the early consumer survivor, ex-patient, ex-inmate movement. That was just one piece. Next slide. We came from a group called the Sponsoring Committee, or Empower, a member-run organization of people who identify as mental health consumers and current and former psychiatric patients, with the mission of advocating for political change and social change within the mental health system. This is a little bit of our history. This is in the 70s. Actually, in the 70s was the Mental Patients Liberation Front, and then in the 80s and 90s, we became Empower, and we really bridged and did this work. So next slide. So Kiva Centers. So the meaning of Kiva is a Hopi Zuni term, which means to go deep within yourself and come out healing yourself. Fun fact about Kiva, we're an indigenous run organization. I myself am someone of Taino descent, which is indigenous of the Caribbean, and our executive director, Brenda Vizina, she has Hopi Zuni roots. And the idea of the turquoise K and the feather is symbolic of liberation. Feathers mean liberation amongst many tribes. So we continue that message of liberation and self-transformation. And again, Kivas being ancestral chambers, where people would climb in and reemerge having healed themselves, whether if it's through contemplation or meditation or many things. And when I say heal themselves, I mean emotionally, finding an emotional direction towards healing, because we often talk about that capacity for healing, but it's very, very important to mention that. So next slide. So Kiva Centers, we are a peer-run organization that support people with social impacts like trauma, mental health, and substance use. Kiva Centers fosters environments for trauma healing, advocacy, self-determination, and mutually empowering relationships. And I think that that's a big part of what we do. Everything that we do as a community is designed by the community for the community, from our peer support groups to what our peer-run respites look like, to what our recovery learning community peer-run drop-ins look like, and all of our different spaces. Next slide. Thank you. So some of our key projects: we train and certify certified peer specialists in the state of Massachusetts. We do statewide and national technical assistance. And I think a big piece of that technical assistance has been that we've supported other states and other countries in starting peer-run drop-ins and peer-run respites. Right now, we're supporting the state of Indiana and starting their peer-run respites. We've had early conversations about that we hope to continue. And we've supported the state of Maryland with their peer-run respite study. And we're connected with the many peer-run respite organizations throughout the country. There's 14 states that have peer-run respites, and there's 50 in the country. We do other additional peer support training, continuing education, some of those key pieces. And we'll talk a little bit about more about peer-run respite in a moment. So let's go to the next slide. So, more initiatives. So we have peer bridging. So we are in state hospitals and mental health acute units in 100 cities and towns in Massachusetts, doing informationals and some of the only non-psychiatric peer support groups that are run by psychiatric survivors, people with mental health disabilities, for people on the inside, and introducing them to resources on the outside, but also focusing from a place of self-determination and otherwise. We also have a Massachusetts Peer Workforce Coalition because there are many different peer support pathways and lived experience professions. There are community health workers, peer recovery coaches, family partners, certified older adult peer specialists, and it's different state to state. So we like to have solidarity and join as a coalition and talk about the value of our differences, and where we can collaborate and where are our similarities. And then we're going to talk about peer-run respites. So we have 2 peer-run respites, and we are opening a third. One is called Caraya, and another one is called Juniper, and our newest one is called La Paz. Caraya is the Taino word for moon, for rest and self-reflection. Juniper is a plant. It's a plant medicine in a lot of ways, in a lot of tribes. Thank you. And then from there, La Paz is the word for the peace in Spanish, and that's an important piece as well. Our community was founded by Latino community members and advocates, and I think it's important to mention that a lot of Latino people have Native American ancestry, and are reclaiming that indigeneity. So a lot of the names and what it's symbolic of is really to take this idea of how we approach mental health from a community focus, and a holistic focus. Because when we think about what peer support is, we practice peer support in our home, at the kitchen table. We practice it in our community, right? At the barber shop, at the library, at the salon. So that's an important piece. In addition, we also have our Kiva recovery learning communities, where we do peer support groups in libraries and coffee shops and museums and out in the community. And we have our own drop-in centers where people can just come by. They don't need a referral or a recommendation. They can come in for support. And again, it is run by people with life experience in that regard. Next slide, please. So a little bit more on peer-run respites. Studies have shown that peer-run respites can reduce hospitalization by 57%. And why is this, right? So I think when we talk about how life experience informs our ideas of disability and health and how we understand each other and community, that context is extremely important. I also think that there's a better guide in terms of sustainable resources that work for us in the wider community, because we know what works well for us. You know, we in a lot of ways are experts in our own journey, you know, because we've had to navigate these systems, and we've had to face that inaccessibility and that ableism and find ways to navigate those spaces. So with that, what we found at our peer-run respites, since supporting 761 people from 2021 to now, we found that people live more fulfilling lives in the community, and in a lot of ways where I find that peer-run respites as a crisis model, when we're talking about mental health, is a fantastic way of fulfilling the promises of some of the promises of the disability rights movement. When we talk about Olmstead and ADA and the right to live in community with fully integrated lives. Our Karaya and Juniper peer-run respites offer rest and self-reflection to all people experiencing emotional distress. So you don't necessarily need a mental health diagnosis to stay at our peer-run respite. I think that that's an important piece, because when we talk about the context of mental health, it is, again, so vast. And when we talk about the context of inaccessibility in society to mental health, we are talking about the presence of negative messages is not as important as the the presence of positive messages are not as important as the absence of negative messages. So for example, if there was a sign that says you are a flight risk and another one that says have a nice day, I'm not hearing have a nice day. I'm hearing that I'm a flight risk. So we think about this a lot in our environments. And again, our community comes together and thinks about, how did I feel when I was in this inpatient space? What didn't work for me? What environments have made me feel great? You know, and then we build and design our peer respite homes after that model, that approach. We support people through what is called crisis, again, to find healing. And, you know, our initiative is statewide. We also have mobile peer-run respite, where we meet people in the community and we support them for up to 4 hours at a time. So whether if that's meeting them just outside of their home at a distance, or meeting them virtually for support, or at a favorite coffee shop or library or place that they like to go to, we are supporting people who are struggling at that moment in time. The great thing about mobile peer run respite is that if you do start something like a peer run respite model, when your houses are full of people and you have a lot of people who are waiting, you can go see them in the community and support them. And the beauty of this model too is that you can introduce people to resources before they come into the peer run respite. You could connect them to alternative means, and you can meet with them multiple times a week. So we may do one session where we meet with someone on Monday, for example, and then we'll do another one maybe on Wednesday or Friday. There's not really a limitation to how often we meet with people, and we don't necessarily define the crisis for them. It is when they need it. Next slide, please. Yeah, so I think just in terms of wrapping up, something that I see in terms of mental health peer run respites and other spaces is that people leave inpatient settings and different settings with sometimes challenges trusting those institutions or trusting resources afterwards. Some people identify as psychiatric survivors. Some people identify as neurodivergent. Some people identify a plethora of ways because of the experiences they have and how they view themselves in society. And I think we don't necessarily need to conflate identity with belief system to understand that we need solidarity as a disability rights movement and as a disability community. So I think something that's so important when we talk about peer-run respite models is really, again, when we talk about that message from the South African disability rights movement, nothing about us without us. We're talking about designing initiatives for ourselves, run by ourselves, as a way of diverting people from sometimes institutions that can really harm them. And again, fulfilling that promise during Disability Pride Month, that we have a right to live in community. We have a right to interdependent life and individual life and independent life. Thank you.
Thank you so much, Vesper, for that. And so we're going to enter into our Q&A portion now. So please feel free to put your questions either in the Q&A section on the Zoom bar. You can email them to me at jenny@ncil.org, jenny@nickel.org. Or if you're calling in, you can hit *9 to raise your hand. And then when I call on you, *6 to unmute. We do ask that you keep any voiced questions to under 30 seconds if possible. So I also just wanted to mention to everybody, make sure that you fill out the evaluation. A link was posted in the chat for you all, and we'll post it a couple more times as well. But please go ahead, fill out that evaluation. It takes about 30 seconds, 1 minute maybe, but it gives us so much feedback. So the first question is, I believe, for Vesper, and this is from Trish. Trish says, in my studies about peer-run respite home centers, I see that sustained funding is a challenge for even really successful programs. Can you address this?
Absolutely, absolutely. So one important piece for peer-run respites is sometimes you have to propose a new piece of legislation to eventually work towards earmarked funding for something that's specifically a peer-run respite. What we've done very uniquely, I think, at Kiva Centers is that we've taken existing respite funding and in our master service agreement, we've written it in a way that is very aligned with peer support ideals and peer support values. And for all clinical requirements or medical requirements, we've outsourced to other agencies and trusted folks, where we've entered a memorandum of understanding and a partnership, and we've trained them in our peer support approach and what we do. So in Massachusetts, it's a Model A respite, which is a blended capacity model respite. And again, it's through a master service agreement. So what we've been able to do is as long as there's a continuing need and there is a, proposals or RFPs that come out for peer run respites, we've been able to put in those proposals, and we've been able to say we want to expand our existing master service agreement. And I'll definitely encourage folks to email me if they need more support and technical assistance around this. My email is vmore@kivacenters.org.
And stay on, because follow up to that, Max is asking, how can we get more peer run respite started in Michigan? There is no alternative to psychiatric hospitalization.
That's a great question. It's interesting, state to state, and I would say that a way to do it is partially to start with legislative action to really propose the need, like, or really talk about and advocate for the need of peer run respite. I would go to your state house. I would have a day, multiple occasions where you are talking to representatives about the need and the rising need of it. And I know that that's not the exact the exact solution here, right? But it's one of many things that we can do. And I do think, to my point earlier, there are existing funds for clinical respites, and there has only been an ample expansion in behavioral health that we've seen these last 3 years. So if you know a peer-run organization that is willing to take on the task, and state partners that are willing to be nimble and flexible in terms of peer-run values and what is needed in that implementation process, and you want technical assistance from an entity that's already doing it, it is very tangible to take existing funds and convert it into a peer-run respite. Yeah.
Great. And Trish just asked if you could put that email that you mentioned into the chat, because the one on the slides is the vesper.more.
Absolutely.
Great. And just a reminder to people, if you have any questions for any of our panelists, please feel free to put them in the Q&A section. Please email them to me, push *9 to raise your hand. And we'll give it about another 30 seconds or so for questions. If there aren't any more questions, I will ask our panelists, do you guys, while we're waiting for more questions, we'll say, Trish actually just asked the question, Vicky, are you available to Zoom with specific centers, HR people, anything like that?
Yes, we are.
Great. And the best email to reach out to is the one that we put in the chat, correct?
Yeah, exactly.
Great. Thank you. That was just a quick question that somebody asked. So I do want to ask, while I have you on, Vicky, do you have any other sort of things that you want people to know about mental health transitions or working with people with mental health through transitions?
So I will try to talk slower. This program came about because the protection and advocacy system used their investigatory power to go into homes where the state was keeping a lot of people with mental illness. They moved them out of psych hospitals and into these other care facilities, thinking if it wasn't a psych hospital, that it was community living. Protection and Advocacy did an investigation, issued a report called Trapped in a Fractured System of Care. That report then led to a filing with the US Department of Justice, who came in and did their own investigation and then required the state of North Carolina to move people out of these institutions that weren't state-run, but still institutions, and into the community. And so this is a settlement agreement that the state was having difficulty achieving until they developed this model program with our center. And I think our success is, one, we're a Center for Independent Living. And so we have a lot of peer support on staff and a lot of peer experience. And using that, we were able to establish rapport with our folks, and we are able to help people take advantage of these resources that the state has to provide people coming with mental illness coming out of hospitals settings into the community. One of the things that is happening is that more and more of the program, the local management entities is what they call them in North Carolina, are starting to look towards centers for independent living because of our peer-run model as a way of achieving better success living in the community. Is that helpful?
I think that was great, actually. Definitely very interesting. So thank you so much, Vicki. And then I will just check in with Alex and Jess. Do you guys have any final departing words?
Hi, this is Jessica. I think growing up as a minor with a mental health diagnosis and being in the hospital, I think one important thing that I did learn was to listen and be heard and believed. That was definitely the hardest part, was not being listened to and not being believed, and then having that impact growing up. And that follow you through the years and affecting me as an adult now. And I'm just about in tears because of just like how that does have an impact growing up, and being remembered of like how hard it was trusting the hospitalizations and trusting whether I should go back on my own or being forced to. And wanted to make the decision, is it safe for me to go? And so having those moments, the last 2 times I went, I had to make that decision. And those decisions were very hard for me because of my past. So, but I am grateful today that I did make those decisions because it was the safest for me to go. But yes, being heard as a minor and believe them, because what they say is so important, what they're going through. They listen to everything and notice everything that's going on around them. So just listen and hear them, believe them.
You are going to make me cry, Jess. I also live with a mental health disability, and it started when I was a minor. And 100% agree with that, because, and also be open to caring about them. Like, it's really hard for anyone, including adults, to speak out about mental health. And so it's really about being open as well. Sorry, Alex, you were gonna say something. Go ahead.
Yeah, not a problem at all. Believe each other. That's a good, if you take nothing else away, that's a good thing to take away. I would just encourage that one thing that was helpful for me is the theory of the rubber band. So as stress and life kind of pulls tension on that rubber band, figuring out what are the self-care things or the support you can do that lessens the tension on the rubber band. So I have days when my mental health's not as great, or when stress or drama is high. So I have a plan for who am I going to talk to, even when I leave this webinar, that this is great, but it's just a little more stress. So how am I going to take care of myself? So that's the last thing I would leave you with is, like, what's your plan to take care of yourself in an average day and when you're having a rougher day?
Great. Thank you so much. Thank you to both for joining. Vesper, any final words? If not, we will do a quick wrap up. Go ahead.
I think I would just want to say thank you all for taking the time today. The mental health disability community, all disability communities are expansive, and it's really great to see this continued dedication to cross disability, cross generational work, and excited to see it moving forward. A little bit about myself: I was institutionalized as a young adult, and that's why I do this work. But I've also found over time, being more and more involved in the disability community, it's an important piece that we are together as much as possible and collaborating on these initiatives. So thank you.
Great. Well, thank you. To all of our presenters. This was amazing. And to all of our attendees, we have our evaluation link up on the screen right now. You can also take a screenshot with your phone of the QR code. Go fill it out, 30 seconds, and we would be so appreciative. So thank you again to everybody, and we will see you on our next webinar. Thanks all.